I'd like to speak about, firstly, who we are and how we work, what we've done on the topic of housing, briefly speak to our latest report, some preliminary notes on the 2012 workshop on housing, which we had last week, and I will be finishing with research gaps, needs, and recommendations. We are Inuit Tutaalmingat of the National Aboriginal Health Organization. We're the Inuit-specific center, and our mission is to advance and promote the health and well-being of Inuit families, individuals, and communities by working in strong partnership to collect information and share knowledge. We'll promote Inuit well-being in this context. So we're governed by Canada's Inuit organizations, the 4 regions of Inuit Nunangat. This map depicts the 4 regions, the Inuvialuit Settlement region in the Northwest Territories, the territory of Nunavut, Nunavik in northern Quebec, and Nunatsiavut in northern Labrador. We are also governed by the national organizations, Paktutit Inuit Women of Canada, Inuit Tapirit Kanatami, the National Inuit Youth Council. And yeah, this is a map of the regions. I had the land claims organizations on there before as well. Now, because Inuit must fly out of their home communities for diagnostic and screening services, for medical treatments, palliative services, and other forms of health care, resulting in significant social and emotional costs, as well as financial burdens to families and for the healthcare system. Because of all that, I've added the cities that are the centers within which those services are provided to Inuit. So in all these cases, Inuit will have to travel by plane and go to the centers, and it's like in the north-south direction according to the transportation of the airlines. So Yellowknife serves the Inuvialuit and the Western Kitikmeot, as well as Edmonton. Kivalliq is served by Winnipeg, Qikiqtaaluk or Baffin comes to Ottawa, Nunavik to Montreal, and Nunatsiavut to either Goose Bay here or St. John's. This is just a reminder that knowledge translation, which is what we do a lot, is defined as a dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health of Canadians, provide more effectively health services and products, and strengthen the healthcare system. So this is the CIHR, the Canadian Institutes of Health Research definition. We mainly work as knowledge users and as knowledge brokers in our work, and this is an example of the work we're doing. We give a forum to Inuit voices on issues of well-being, health, and paths to recovery. For example, we organized a panel on Inuit healing practices as shared by female Inuit elders and prepared video clips that are available on our website. We capture Indigenous voices from the community and individual level and deliver to Indigenous communities, service providers, and researchers. For example, we prepared a report on the 2008 workshop on housing and are now preparing a report on the 2012 workshop that we had last week. Because NAHO is publisher of the Journal of Aboriginal Health, we're particularly thrilled that we will have a special issue on Inuit health research and community innovations, and we currently have a call for papers out, and you can see the call here, and the deadline has been extended to April 30th, so we invite you to submit not just academic papers, but we're also hoping to get contributions from community participants in research to get the community story, and also book reviews. We work on a wide range of topics such as housing, food security, economic development, mental wellness, maternal and child health, men's health, and youth health. And our materials are used by also a wide range of audiences, by community health workers, colleges, training programs, regional Inuit organizations, and provincial and territorial governments. Just to recap again, social determinants of health are the World Health Organization defines them as the conditions in which people are born, grow, live, work, and age, including the health system. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels, which are themselves influenced by policy choices. This is taken from the 2010 World Health Organization document. Lappi, Reding, and Wien noted in 2009 that social determinants of health framework highlights how individuals, communities, and nations that experience inequalities in the social determinants of health not only carry an additional burden of health problems, but they are often restricted from access to resources that might ameliorate the problems. For example, Inuit have limited access to appropriate and affordable housing, leading to overcrowding and thus making Inuit more vulnerable to communicable diseases such as tuberculosis. The 24 workshop we had 2 weeks ago, the overall theme was that Inuit expressed that they feel they're at a turning point in terms of housing, that things will need to change, and at the turning point in terms of particularly also research has to be more applicable. And despite the regional differences that are there from east to west, there are very similar pressures in all the regions as well as felt in urban communities. And also the difficulties are pretty much the same in providing healthy homes to community members. The report that we just published before Christmas, If Not Now, When, addressing the ongoing Inuit housing crisis in Canada. It's the latest in our series. And the report has 3 sections, purposefully divided so that they actually stand on their own. You can read each section on its own, and it hopefully will make sense, we think so. Research evidence relating to inadequate housing conditions to ill health. Next chapter is contextual information on the state of Inuit housing, and the last one is a discussion on the determinants of health framework as a research to action tool in the context of Inuit housing. Now, this is just a recap. You probably all know these are the latest, to us, the latest available numbers on the health status of Inuit in Canada. In almost every indicator of health, Inuit score lower than the Canadian population, and example is life expectancy. For example, in 94-98, the life expectancy at birth was significantly higher for Canada as a whole than for residents in Inuit Nunangat, with an overall difference of 10 years. Now, this is also the case between 1999 and 2003, where that difference grew to 12.2 years. And the change is a result in an improved life expectancy in Canada as a whole from 78.3 to 79.5 years. And the decline, and this is the important thing, the decline in life expectancy in Inuit Nunangat from 68.3 to 67.3 years. Infant mortality is another indicator that's always used. When compared to Canada as a whole, the infant mortality rate was 3.3 times higher between 94 to 98 and 2.8 times higher between 99 and 2003. The mortality rate in Inuit Nunangat was much higher than that for Canada, 2.7 times higher. The highest cause of death in the Inuit homelands is unintentional injury, followed by suicide, self-inflicted injury, and then respiratory disease, which we will see is related to housing. Lung cancer rates among Inuit in Canada are the highest in the world. This evidence is all available. We just made an effort to present it in a way so that hopefully it is clear how this connection works to housing, and we're following some recommendations on how research could be done in a way to be closer to recommendations for policy or implementation. Indoor air quality and infectious diseases, hospitalization rates for Inuit children with severe lower respiratory tract infections are the highest in the Western world. Dampness and molds, often indicating structural weakness and need for repair in the building. Now, we don't see dampness and mold that much in Nunavut, but we do see it in Inuvialuit and region and in Nunatsiavut. Problems associated with this are asthma, respiratory tract infection, respiratory symptoms, rheumatic fever, and psychological distress. There's strong associations between indoor CO2 levels and the risk of lower respiratory tract infection among Inuit infants and young children. Tuberculosis. Between 2004 and 2008, tuberculosis doubled among Inuit. The Canadian tuberculosis reporting system indicates Inuit having 155.8 incidents per 100,000 individuals, while the overall tuberculosis incidence rate in Canada stands 4.7 per 100,000 persons. The lowest rate among Inuit is found in Ontario, where the rate of 52.8 per 100,000 persons is sadly still more than 10 times the Canadian rate. Tuberculosis rates are directly related to inadequate and overcrowded housing, food insecurity, and access to health services. And today, I don't know if you've seen in the Nutsyak News, is a report that says, faced with the high numbers of active tuberculosis cases, Nunavut's health department of the government of Nunavut plans to boost its TB screening, prevention, and treatment efforts into 2013. Living in crowded dwellings, we've tried to collect everything in literature that we could find about the relation between crowding and health, because it is such a prominent factor for Inuit housing. Crowding living conditions have been a challenge Inuit had to deal with for generations. According to the 2006 census, using the person-per-person room measurement, 1 in 3 Inuit in Canada live in crowded conditions. You can see on the chart it's highest for Nunavik, where about half of the population lives in crowded conditions. And it is chronic. They're not just doing it for a year, they've been doing it for decades. Considering the demographics, this is something we also like to point attention to. In 2006, Inuit were the youngest Aboriginal identity group with a median age of 22 years versus a median age of 40 years for all Canadians. By 2031, the median age of Inuit will be between 31 and 32. For Canada, in 2036 in Canada, the range will be 42 to 45 years old. So the majority of Inuit right now are under the age of 25, which means that program and service needs are greatest in the areas of child health, education, and youth. And the main point here is likely that this is the focus of the programs need to be on an age group different than for the overall and the rest of Canada. Children living in crowded dwellings, so considering that half of the population is younger than 25, we're looking back at the crowding situation. 49% of all children under 6 years of age are living in crowded dwellings, so more than the overall rate is 31. We have half of the children. And even here, the highest rate is Nunavik with nearly 60%. The Nunavut Inuit Child Health Survey conducted 2007-2008 found that the numbers of children living in crowded conditions are even higher if we consider preschoolers only. So if we go looking at a younger cohort, the survey identified that 54% of preschoolers living in 16 Nunavut communities were living in crowded homes. That's over half. Crowding and infectious diseases. The relation problems associated are colds, coughs, influenza, cramped muscles, cold sores, tuberculosis, skin problems, lack of sleep, anger, depression. Crowding and well-being. It is a source of stress. We find a lot of literature on this. However, the research is not conducted in the Arctic. Hardly any of this is actually conducted in Canada. A lot of it comes from the States or from other countries. Crowding can lead to frustration, anger, violence, spousal abuse, increase of crime levels. Crowding has a negative impact on learning outcomes and behavior. We found quite a few studies in the US that confirm this. And there's a large gap in research on housing and education skills development and employment outcomes for vulnerable groups. And this is a finding, not our finding, this is a finding from Canada Mortgage and Housing Corporation report in 2010. Our 2012 workshop, we had several comments that focused on mental health, really trying to communicate the great need to look at the relationship between housing and mental health and crowding and mental health. The points being made were that people living in these conditions of crowdedness have already gone through trauma. So we're dealing with multiple trauma and cumulative impacts at the individual levels. We know that crowding conditions create chronic stress, but there is also following for physical diseases and unhealthy coping behaviors. And this is something we think there's a big need for research. Local treatment capacities and facilities are lacking in communities. So if we're thinking at programming to remedy the situation, there are no facilities right now. So we're looking at big changes. And language and cultural barriers in urban settings. That's for example, in Montreal, deal with three or more languages and not their own language, so it's really hard to get access to programming in their own language. There's a need for addiction treatment facilities and programs in all Inuit regions. Housing quality, there are many problems as well. The dwellings are aging. A lot of the problems with the repair requirements of buildings comes to the wear and tear due to the cold climate. In the latest report of Canada Mortgage and Housing Corporation, their statistical profile mentioned that very clearly. That also came up actually in the housing workshop, that the materials that are currently used are really not always the best. Not only often not built for the cold climate, but also not the best. Many obstacles exist in the repair and maintenance of the buildings, lack of public and private funds for repair, low incomes, absence of temporary housing to relocate residents during maintenance and repair operations. I don't know if you've followed in the news the horrible fire of the 22-unit building in Inuit. It's really hard on the people. There are no extra buildings where people could be moved to. So the mayor and the city did a really great job to find a place for all these families that lost their homes. Erosion and permafrost melting make buildings unstable, and damages and the decline due to weather conditions and the high number of occupants all contribute to it. The children living in dwellings requiring major repairs, here is another statistics, a third under the age of 6 live, and these buildings require major repairs. So this is not just beauty repairs. These are real problems with either the sanitation or with the walls. Housing and the urban experience. Crowding contributes to migration to urban centers, and we've heard this repeatedly, particularly from Nunavik. The urban Inuit population is growing fast. In 2006, about 22% of Canada's Inuit will live outside of the homelands. The homeless population is increasing. Montreal created an action plan against homelessness because of the high proportion of Aboriginal people in the homeless population, and Makivik negotiated the first Inuit caseworker to help homeless Inuit women in Montreal, which is an example of how little services is catered to Inuit. And this is our finding, the need for solution-oriented research, and it relates back to the title of our report, If Not Now, When. The social determinants research is still in its infancy, and the Inuit public health sector. And this has been noted before by other researchers. But it really needs to happen to help identify points of intervention for example, respiratory diseases or tuberculosis. The determinants of health include contextual and historical perspectives on Inuit housing. Also, there's a need to consider the population-specific demographic profile. We don't see many studies or policies that consider the specific demographics of the population. There's a large gap in research on housing and education skills development, as mentioned before. Collaborative health research with communities on housing conditions and their influence on health is sporadic so far. To develop health research with communities will provide and increase local relevancy. Health research is much needed, for example, on the association between housing conditions and mental health and problem behaviors. And policy research is needed to have an overview of the currently existing policies and to identify how existing policies can be adjusted. And this is to show that there is a shift necessary in how research is done to close the knowledge translation process.